We'll try to focus a little bit about one of the most common problems that we have in our ICU patients, agitation. When a patient is agitated and is under mechanical ventilation, he may develop some degree of asynchrony, and then we sedate the patient. But the problem is what kind of sedation we choose in our patient, because when you have an agitated patient, you may sedate him, and then you can increase the risk to develop asynchrony, because it depending from the choice, from the effect of the drug that you are choosing, because there are some sedative drugs acting on respiratory drive, and there are sedatives drugs acting on respiratory timing. And also the dose, it's important, because if you have over-sedation, you may have a lot of asynchrony. And this can be representative of an agitated patient. She was a female with trauma patient, with a trauma, and as you can see on the electrical activity of the diaphragm on the top, the flow tracing and the airway pressure tracing, this patient breathed at 76 breaths per minute, while the ventilator was able to catch almost half of all the respiratory rate, 42 breaths per minute. She is definitely a patient that needs sedation. And why we have to sedate our patients? As I told you before, because we have to improve patient-ventilator synchrony. We have to modulate respiratory drive or respiratory timing so that probably we can get an earlier weaning. And if we are able to wean a patient earlier, we definitely may reduce the short and long-term side effects related to mechanical ventilation, like ventilator-associated pneumonia. And that asynchrony, it's important in our patient and is associated to a prolongation of mechanical ventilation, was already demonstrated by Laurent Brochard group. In this study, they showed that the patient with a high level of asynchrony index above 10% had a significantly longer duration of the mechanical ventilation, and this is clearly related to a significantly increase in the risk of tracheostomy. And these results were further confirmed by the DeWitt group. In this study, DeWitt and Cole evaluated the percentage of ineffective triggering in two groups of patients, and the group with a high percentage, with the thick black line, high percentage of ineffective triggering, had a significantly longer duration of mechanical ventilation. But in this duration of mechanical ventilation and in the asynchrony, we have to take in account the sedatives that we are going to use. And the same group evaluated the relationship between the sedative used and the possibility to have patient ventilator asynchrony. And they showed that some sedatives, like benzodiazepines, like lorazepam, or GABAergic, like propofol, may significantly increase the risk to develop patient ventilator asynchrony compared to other drugs. And then, when we use a drug, we have to be really careful, because when we oversedate our patients, we also increase the risk of patient ventilator asynchrony. And this can be the effect of, for example, a propofol infusion with oversedation. As you can see from the top to the bottom, electrical activity of the diaphragm, flow, and airway pressure. The electrical activity is really low, and you have some effort able to trigger the ventilator, and then you have some wasted effort. But this is not just the case of a patient ventilated in pressure support, like this one, with an oversedation. This can be also a patient in which the setting of the ventilator was not perfect. It's not the topic of my talk, and the other speakers will enter and will focus on patient-ventilator interaction in terms of the new modes of patient-ventilator interaction. But look at this tracing. This was the original patient tracing, electrical activity, flow, and airway pressure. And He was ventilated with 10 centimeters of water of pressure support. If I go back, this is the same patient in which I drastically increase of 10 centimeters of water the pressure support, and I obtain exactly the same decrease of the neural drive as demonstrated by the electrical activity of the diaphragm. So when we choose the sedative, we have to be careful, because when the choice means that some sedatives act on respiratory drive, other sedatives, mainly opioids, act on respiratory timing. How GABAergic, for example, propofol, may act on respiratory drive. This was elegantly demonstrated by Rosanna Vaschetto from Paolo Navalesi group, and they studied a group of patients in ICU in awake condition, and after applying a light level of sedation or a deep sedation. And as you can see on the electrical activity, in the wake sedation, the neural drive was pretty high. By applying light sedation, the neural drive is lower, as demonstrated by the IDI peak, that it's lower. And when the sedation was a deep sedation, the drive was so low, and we have an increase of the wasted effort, and so we have a worst patient-ventilator interaction. And the effect on propofol are not just on drive. The final effect, it can be the high level of sedation, a deep sedation with propofol, may significantly increase the CO2 level in our patient. And especially in the group of patients that were ventilated, in the patient were ventilated with pressure support, it was a significant increase of the percentage of ineffective triggering. While using a mode of proportional assistance, you probably may decrease the percentage of ineffective triggering, but you have an important effect on gas exchange. How about opioid? 10 years ago, we published this paper in which we evaluated very low doses of continuous infusion of sufentanil in a group of ICU patients. The dose was in between 0.02 and 0.03 micrograms per kilograms per hour. And our results showed that this dose was able to allow the clinician to have an awake analgesic sedation in our patient without any effect in terms of tidal volume that was constant for the whole course of the study, respiratory rate that didn't decrease significantly, respiratory duty cycle that it kept constant. And at that time, we did not have any direct evaluation of neural drive, so we use an indirect measurements of the neural drive, that it was the P01. And as you can see, the P01 was constant, and we did not have any modification of the drive of the patients with low infusion of sufentanil. And we found the same results with remifentanil, with a different pharmacodynamics characteristics, and we showed that low doses of remifentanil were able and useful in patients to reduce and to modulate the respiratory pattern. But why we found these results? Now we studied different and increasing doses of remifentanil, of a continuous infusion of remifentanil, in a group of our patients. This is a patient tracing. This was an awake patient, electrical activity, flow, and airway pressure. This is the worst patient that we enrolled in this study. The respiratory rate, the neural respiratory rate was 62. We have some wasted effort, and we have an high drive with a peak of the electrical activity around 20. And after the infusion of remifentanil at the dose of 0.05, as you can see, the neural respiratory rate of this patient was decreased, and the timing, the neural timing was definitely modulated, but we don't have any modification in terms of drive. The peak of the electrical activity was always around 20. So the effect of remifentanil is definitely more on respiratory timing and not on respiratory drive. And this is just to show you that from the dose of 0.05, remifentanil infusion was able to reduce the respiratory rate with the black line without any significant effects on the swing of the electrical activity. How about the respiratory pattern? We did not observe any modification in terms of neural inspiratory time, but when we went to see the neural expiratory time, we observed a significant prolongation of the neural expiratory time from the dose of 0.05 with a concomitant decrease of the neural duty cycle. How about gas exchange? We did not observe for any dose that we administered to our patients any effect in terms of CO2. And the CO2 was constant for all the infusion. So we concluded this study thinking that remifentanil is able to reduce the neural respiratory rate, especially for doses higher than 0.05 micrograms per kilograms per minute, without effect in terms of gas exchange. But we have to be careful, because some of our patients had to run out from the study for dosing above 0.08. So it means that 0.08 should be considered as a cutoff value, above which sometimes the patients are at risk to develop bradypnea. And now about new sedatives. Dexmedetomidine, it's an alpha-2 adrenergic receptor agonist that can allow us to obtain a good level of sedation with side effects in terms of respiratory pattern. This was a study published in 2000, was conducted on healthy volunteers, but in this study, the authors elegantly showed that continuous and increasing doses of dexmedetomidine did not produce any modification in terms of CO2 and in terms of respiratory rate. So I'm going to present you some preliminary data from a study that we conducted in our hospital comparing propofol and dexmedetomidine in a group of ICU patients. And this is a patient tracing on propofol. We want to obtain a good level of sedation, but as you can see, during the propofol infusion, you have not a rhythmic ongoing of the electrical activity of the diaphragm. You have some high drive moment, and then you have very low drive moment. And if we focus on this moment, you can see that here you may increase the risk to develop wasted effort, and you have probably some apnea. So this is the risk of an infusion with propofol on long term. And now about dexmedetomidine. This is the same patient sedated with dexmedetomidine to obtain the same level of sedation we were obtaining with propofol. As you can see, the rhythm of the electrical activity is maintained, and if we focus on few seconds, you can see that there are no many changes in terms of the peak of the electrical activity, and this allowed the patient to maintain probably the synchrony. So when we speak about sedation, we have to be careful, because independently from the drug that we want to use, we have to be aware that on the effect of different drugs may have on respiratory drive and on respiratory timing. We have to be careful because we can over-sedate our patients. And so we sedate a patient to improve synchrony, but at the end, we worsen patient ventilator synchrony. How about new sedatives? Definitely, these sedatives may represent a new frontier in Europe, because in the United States are already used. And it's definitely the results about dexmedetomidine and the no effects of respiratory side effects should be demonstrated by other studies. But these studies, the study that it's ongoing now, it's clear in demonstrating that sometimes when you use dexmedetomidine, you can reduce all the side effects on drive that you can obtain with propofol. Thank you very much.